This is Impact Healthcare.
Attention. This podcast has been disrupted.
Welcome back to another episode of the Disrupt Healthcare podcast. This is going to be a fun one, as this person and I have probably done, 20 or 30 video type interviews and things in the past, but this is the first one as Disrupt Healthcare, and this is the first one in her new capacity. Rachel Strauss, for our audience that maybe doesn't know you and the new capacity that you are in, give us an introduction to you and your wonderful organization.
Absolutely. I am Rachel Strauss, founder, CEO of PBM Princess Consulting. And I get asked on almost every podcast, why PBM Princess? And here we are, Lester. You are indirectly who named me this. Fun fact, during the pandemic, I worked, my previous employer for a long time never had titles. And I was on one of those 20 or 30 podcasts with you speaking about the EpiPen, which we did a lot during the pandemic and talked about, cost savings opportunities within that category alone. And I had no title. So as a joke, you just said PBM Princess. And I mean, I kind of didn't hate it. So Lester Moritz, you gave my moniker that I took to a new level.
You will have to be careful because apparently I'm a big Bad Bunny fan, and apparently the girl that recorded Bad Bunny Baby came back 3 years later and asked for $5 million. So, be careful. Rachel, I'm going to start this conversation differently than what we anticipated, because I think one of the things that this conversation does to me is it reminds me why I get up out of bed so fired up, which is I don't think half the world knows how impactful these strategies that we're going to talk about, the nerd part of our conversation, is on the human aspect of it. So I'm going to regurgitate my conversation, and I want you to go into why you get up in the morning. So I am 15 years old. My dad is diagnosed with multiple myeloma. That is cancer of your bone marrow. He has a bone marrow transplant, chemo, and radiation, and Dad is prescribed a drug called Revlimid. Revlimid's roughly $150,000 a year, and back then, this is late 90s, was still a little bit on the experimental side. So some of the insurance coverages didn't cover it. My parents didn't have coverage for it. They were deciding make your mortgage payment or keep Dad alive. That's an easy decision. And my parents go bankrupt for this. Knowing what you and I know, this is not an uncommon story in regards to the high cost of a medication has some other way of doing it rather than the normal way that we are taught that 98% of the people that are going to listen to this podcast are doing, that could impact a human life. And I know that that drives you every day. So make that the foundation of your explanation as to why you just left a role for a company that you were working at for 20 plus years. Talk to me about the passion for you.
For me, it's always, Lester, been about the patient, right? Whether it's somebody we love. I have had a child go through heavy medical bills. He had open heart surgery at 5 weeks old. I have had to be the fighter, the advocate on behalf of a patient, all the way down to the nuances of just friends who know I work in health insurance and send me their open enrollment guide fourth quarter and say, just tell me what plan to pick, and have no idea what it's about. For me, what has always driven me are those people, right? It's the people who utilize our healthcare system and don't understand how it works or how they can contribute better to it themselves as a consumer or as a patient. I'm blessed that I had a 23-year career in the pharmacy benefit space, all with one company. Very proud that I get to say that. And really, for me, it was the evolution of where I wanted to go. Thanks to, quite honestly, you. I will give you a lot of credit, Lester. You give people in our space a voice. You made a joke in your prep video about getting high on our own supply, and that is because we do get excited. I do listen to them, like half of them, but I did listen to that one yesterday. And, when we are amongst people, it's very easy to get in this echo chamber of, doing what we're doing and fighting this fight. And because of the podcast that I sat on with you and really understanding, I believe all of us, people listening, people on your shows, people in our ecosystem, have this voice and passion. And it is time we get it out of the echo chamber that is our own space. And, the only way I saw that I could do that was going off on my own. I have a lot of, passion as it relates to the pharmacy benefit space, but the more and if you're listening to this and you're a service rep or you're in sales and you're calling on your solution to different brokers, you know, recognize your role in all of this in that we are solution providers, right? We're not just, if you pay attention and you meet the people that are in this healthcare world, you meet other solutions. And when things really work, you want to shout their stuff from the rooftops too. And I got to the point where I just realized I could no longer authentically only represent one brand anymore. And honestly, did it for 23 years, great company, slept great at night, and helped a lot of people doing a lot of different strategies. But I thought I could do more. And so I launched PBM Princess just because I had a built in brand and it made sense to really help solution providers in our space brand evangelize, because that's what I've learned I am, is when I believe something can work, I want to tell everybody about it. And I've also recognized that there's just excess in this industry and a lot of people who have taken advantage of some of the programs, like you've mentioned before, with even finding Remicade, right? We want to get these solutions to the Revlimid, not Remicade. We want to get these solutions to the most people possible. And so that is what I've launched this firm to do. Part of it is advocacy. Everything from, and this can be a story that we go down another path because you're going to say, what? Like helping a Bravo housewife with her own medical bills, and she publicly has talked about it, all the way to helping small businesses that are fully insured find out there are ways that even they can save on things like medications. And that's what I want to do for this. That's my career.
For the, for maybe the people who are listening to this, right? So, having studied some stats, it's probably a third, roughly employers, advisors, and solution providers of sort that kind of consume the content of this. And I'm going to go for the people that might not understand what I would call the low hanging fruit in the pharmacy side of this business. Let's start off with the stats, right? Like how few people consume X amount of dollars and things of that nature. And let's talk about how impactful just targeting the pharmacy spend for an employer can be for all of those constituents that we just talked about.
Absolutely. So pharmacy costs are, it used to be, Lester, that pharmacy, when you looked at the pie of the healthcare, puzzle, if you will, pharmacy used to represent between 15 and 18% of the total spend. In a healthy health plan, I would say that number is probably between 22 and 25%. When you get above 25%, it is no longer a small piece to ignore. And the problem is you're seeing classes of medications come out every year and costs are not going down. So if you don't get a handle, whether you're fully insured or self-funded, on the pharmacy strategy, you are missing out not only on opportunities that could exist today, right now, but you are not shielding yourself from future awful, ugly renewals. And, I was just on Fox News this week talking about the ACA, which is, I think, what is getting a lot of attention in the press right now, and talking about these high percentages that are going to happen in January. And, there's a lot of people out there not getting subsidies, or they won't be able to get subsidies. They may choose not to get health plans. And a lot of those people might be the healthy people. And that is going to continue to put additional resources, that we just don't have for healthcare. So I was asked, how can we help? And this was the answer that I want to say now every week, because it is employers that can do this, right? They can really start paying attention to what they can control. And that is understanding what kind of benefits you're offering your employees, right? I'm sure that your listeners know if they're in a fully insured or they pay the same premium every month type plan, or if they are paying, a percentage of claims before a specific or aggregate self-funded plan. Either way, your employers are consumers of these programs, right? You encourage on work comp. I've been to so many factories in my life where I've seen, the sign that says this many days we've been accident free, right? Because that helps the employer keep costs down, right? The less days that people get hurt at work. And in order to do that, it's a team approach, right? You've got safety and people there that are working towards that being as high as possible, because the more days that go forward without accidents, the better it is for everybody, because there's more money within the company to pay their workforce and reward them. That same concept needs to be taken in the health space, right? And I'm not suggesting we have a workforce that takes no prescriptions. I'm suggesting we have a workforce that's educated about the health plans that they're given. So if you're listening to this, it's everything from understanding what are your employees today paying for medications, right? What is their out of pocket? Are you in a high deductible health plan? Are you in a limited formulary? Really communicating with the consultant to understand what type of benefit package you have, not just what you picked on the spreadsheet because it made sense from a contribution standpoint. Then it's understanding, the health of your employees. We are at a time, unlike any I've seen in my 20 plus years. Data is available even on small group. Here in Texas, even under 20 can get certain elements of data. It's not amazing data, but you can at least start seeing, do you have diabetics in your population? Do you have, a lot of anti-anxiety medications within your population? Really trying to understand where are your members using the health plan, and then trying to format a way that it works for them. So here's some, low-hanging fruit, and we'll talk about this at the end of the episode. But here in Texas, there are so many unique strategies that are, some of them state specific, but have other states that do similar concepts. Things like going to community hospitals and seeing if they will work out a deal with the employer group. And a lot of them can bill fully insured plans. But getting medications at what are called 340B pricing. It's a concept that enables an employer to work more direct with a local pharmacy. And if the pharmacy can bill your carrier and it's a lower price to begin with, everybody wins. So there's just, another really cool strategy. I know case studies we're going to talk about, but this was one that was just an amazing one to me, is there's a company here in Texas. Again, they're going to be in other states soon, but right now it is only here. But it's a medication recycling company, meaning they get donations from hospital systems, unused, unboxed medications. They their FDA, OSHA, everything to recertify the drugs. They're brand new, and they give them back out. They just give them with a dispensing fee. We're talking about 90% price reduction. So that's really great for groups that have cancer medications in their mix. Great case study. We were looking at a municipality. They are currently with a PBM that is through a consortium, several thousand lives. But I found 4 drugs that were in that top 10 report, cancer drugs, within a 20-mile radius of this pharmacy. And we got those medications. Members paid $0. And these cities saved 90% on those drugs. Like that. They just got the members the medications at no cost. So the point being here, to kind of take this full circle, is just knowing, what type of usage are in your plans and starting to figure out what strategies make sense under the umbrella of the plan you're offering.
So to make sure people kind of understand how what I'm going to call basic or little work can be done to make that huge impact. You just stated, hey, 4 people, 90%. What are those percentages as far as the percent of the population that spends X amount of the spend?
Sure. So typically you're finding in a plan, you're going to see, it's kind of like the 20/80 rule, but it's a little bit less. It's more like 5% of the population are typically using the most expensive medications in a plan that can sometimes equate for 85 or 90% of the cost of the medications.
So let's play with those. I've always heard 1 to 3 is 60, 5 is 90. So let's just play with 590. So that means 5% is roughly 90% of the cost. Let's just play with that number. So, let's just do math, right? That is 5 people out of 100. So if you've got, 200, that's 10, and then 300. So this is very low hanging fruit in regards to, hey, these are these 3 or 4 or 5 people. Those people, and again, I'm gonna cage this conversation with, I want you to confirm that this is true. Those people are typically taking one of those medications. You see a commercial on TV, right? An expensive drug. This isn't your amoxicillin. This isn't your everyday anti-inflammatory. These are high cost medications.
Correct. You are on the ball. Yes. If I cost, just so our listeners understand, I'm talking anything between 3,000 to and up a month, upwards of 25,000 a month, depending on, the diagnosis. But to you or me, $500 sounds expensive. I don't want to pay $500 for anything a month. It's not fun or shoes, right? I mean, that is not a fun thing, but to live, it's a choice some people have to make. But when I'm talking expensive to a plan, we're talking about 3,000 or more every month.
So 3,000 or more every month. So that's, if I'm doing math right, we're talking $36,000 to, 250 plus $1,000. So we're talking a substantial dollar amount. These medications are 5%, so very small quantity of people drive a significant amount. Now, I have to ask myself, if that is the case, if I was the insurance company, I would just focus in on those 5 people. Why is this such a thing if it's such a small number of people, and the insurance company theoretically knows who they are because they're the one that's transacting the actual drug? So if I'm on Stelara, my insurance company processed the claim that says I'm on Stelara and we could do something about Stelara. Why isn't that happening?
Because there's a lot of vector beatings that are happening. And a lot of this has to do with what is actually the profit side of the insurance business. And that is pharmaceutical companies' rebates and what they're paying. We are living in a world where, without any explanation of this administration, unfortunately, you cannot say the man's name without having any form of a reaction. But he is the current president of the United States. Trump did make a comment about a month ago that was, basically saying that he wanted, if drugs could be cheaper in other countries, they should be the same price here. And it's a fact. So, like I said, I'd never get political, but we have to look at the statement. And the reason pharmaceuticals are so much less expensive in other countries is because there's not these multiple layers of how the drug gets to the consumer. In our country, those dollars are earmarked. So in this case where we're talking about a $3,000 drug, it may not actually be $3,000. It may actually be $1,100. The problem is what is that chunk of money doing? That chunk of money is going back to the very entity that is allowing the claim to go through in your part, in your point, because somebody else is making that money. And that, in a fully insured environment, that is usually used to offset, premium plus profit. So believe me, your carrier is making money and they're giving themselves that money back, but you're seeing the full cost of the drug when you get your experience. Oh, go ahead.
But before you go on, so funny because it just dawned on me something. I don't know why. I guess my coffee hasn't kicked in from this morning. That's an interesting thought. How many times have we heard a insurance company show a report that says premiums were paid of X and claims were paid of Y? So in the example that you were saying, let's just play with a dollar. I paid $1 in. I got $1 in. I'm the insurance company. I got $1 in of premium. I paid out $1.05 in claims. Wah, I lost. But from what you just said, there are other sources of dollars that are being around here that maybe I didn't lose on that account. I might have actually won one.
I just did this for my husband. If you've listened to any of our shows, my husband's a consultant. He does have level funding. He's like any broker out there who's going to have groups of all different. I don't want to make him a bad guy. He does have some buka business. But he was it's showing me that exact situation. It was one of his level funded carrier programs with a terrible loss ratio. And he just looked at it because he said, hey, can we do anything with these drugs? Of course, he's going to ask, his own wife. And I started looking at the average of prices of some of the medications on the top 10 list. And I'm like, Levi, like if you look at this drug, even on GoodRx, it's under $10. They're showing you a $90 price point. Like that, forget it, just spread. But you have to question everything in those loss ratio reports because oftentimes they're showing you for the incurred, it's a bogus number because it's not actually what was paid out. It's more reflective of a cash price. And that's kind of, when we get into how do you if you can't leave a buka, how do we start to control some of the things that are on the other side? And that is with getting your own access to transparency. It's almost like if you are the doctor submitting the claim and then it's your own family member that gets the ERV and it shows what the doctor submitted and what the doctor was paid. And they're like, wait a minute, I never submitted $6,000 for, a pap smear. That's crazy. But that's what they're showing on the carrier side. And by the way, that's also how they're like, oh, we get, sick discounts, Nick. Right. And so it's really just figuring out ways for employers to get a little bit smarter in the game. Even if they're locked to a carrier, we understand that there are circumstances that the carriers are there, but it's especially as the nonprofit ones, figuring out ways that we somewhat beat the system and get enough data back to leave and create more, better plans.
So we talked about that fully insured client. Let's move over to the self-insured client. Let's keep with Stellara as the example. Like somebody is on this expensive drug, and I was in a meeting yesterday with a very large company, not very large, 3 or 4,000 employees, and they on Zoom show me a report, and on that report was like claimant 2, it was like I think 25 claimants. It was like just their large claims. It was like 2, 4, 9, 13, and 16, and 24. And next to them it said RX. And then it had some ridiculous price tag, like over 100,000. And they're like, well, of course our renewal's justified. Look what our people are spending. And like, I just started laughing. And she's like, is something funny? I was like, it's kind of comical that I can see a report that says you're paying your broker $280,000 and they can look you straight in the eye by showing you a report that 7 of your top 25, claimants are drugs. I guarantee all of those drugs have a better source. So talk to me about that whole piece of it, that an employer's sitting right now at this time of the year, probably looking through data. They're getting incomplete and very like vague data, but this is some impactful stuff.
I mean, to me, I have yet to have a drug. So I have been on my own for 4 months. I have probably had close to 100 groups sent to me my way, like, hey, I have this. Hey, I've got that. Can you do something with this drug? Like just spot check. And this is part of why I left because I wanted to be able to have, if I didn't have the strategy, I wanted to be able to go find it. And every drug has some form of a strategy. I'm not saying we're going to get the drug free, but every single one should be every drug over $3,000 I'm going to say firmly, should be discussed as to what are we doing about this? What are the options so that you can present them? And in every case, it should be figured out the best way to do it. And, we're coming out of a world. Listen, I think for the last 10 years, the industry that has been created, that Lester, you have highlighted throughout your career, and as long as I've known you, almost 10 years, we have shown, yes, there have been ways to get drugs for free. There have been patient assistant programs. But, as those programs continue to evolve, there are more ways that employers can look at that are past just meeting income barriers or finding a coupon and reorganizing what's really a rebate all over again. It's looking at where is the medication coming from? Is there a way to get it, through, as I mentioned, a community hospital? Is there a way international, right? I mean, international right now, I know there's tariffs and there's things. It is still legal to get these medications from another country. I, in my seat, only support tier 1 countries. That would be on, Israel, Canada, the UK, New Zealand, but seeing what their price is on those medications. And you also have to be smart enough to know how rebates work with your plan. And, I could give many examples of sometimes rebates are going to be better, but oftentimes, unless you are in a contract where your rebates are paid monthly, it's actually smarter to get the medication directly from, Canada or another source, or even with a group of the size you just mentioned, it's looking at if they should be negotiating their own contracts or looking at their own rebate contracts and getting away from other components that are meddling with their overall claims. The bottom line is that if you are not attacking the claimant level of pharmacy claims and not just AWP and looking at the, and for listeners who don't know that term, like if you're just looking for the best discount out there, you're missing the mark because it needs to be the strategy of when that drug comes, not for how many discount points you bought it for.
So Rachel, I want to dig on those two maybe as we cross over the halfway mark here, because I think that they're very important. Let's go international first. I want you to explain international because I have obviously done a lot of these myself, and it's funny to get the range of what people are thinking when they think international. Like some people are like literally thinking side alley, Tijuana, whatever. And like what the real answer to this is like, you don't see a bunch of, people dying in Canada on the side of the street because they're medicated. Like it's the same thing. So talk to me about the whole international thing and why employers really need to be paying attention to this.
The international thing is really just a different mechanism of bringing medications into the United States from the exact same manufacturer. We aren't talking about like type medications. We are literally talking about the exact same bops that came from the exact same manufacturer. Israel is one of my favorites just because a lot of people don't realize that a lot of the pharmaceutical companies are based in Israel. They're there. So it's not like going from Israel to the United States, back to Israel to us. It is actually already there and you're saving on before it comes here in bulk. So even with the tariffs and things that are coming in, the medications that are made overseas, especially those that are in the UK, New Zealand, or Israel themselves, because again, you've got Teva, you've got Pfizer with their own labs overseas. Some of these medications are already over there and they're coming here anyways. So from the member perspective, the way this works, it cannot be mandated. And that's why I said everything's an option and employers can figure out how they want to structure their plans. The cleanest, easiest way is just to make members aware that these medications can be received through an international source and align them with that source and just say, here's the contact, here's the pharmacist, here's the fax number for the prescription, and then the member gets their medication shipped. It's not as easy as, the doctor themselves in the beginning writing the script to the local CVS, but again, the member can get the drug for free. And again, it's the same box. So the stigma when they're coming in from another country, and that's why I stick to tier one countries that, by the international standards, and also where there's somebody that speaks English, that answer the phone full English, that's important for patients and to understand the safety and efficacy of the medication. But, you know, it's really not that different than how it works today, only because the majority of specialty medications are sent through the mail. They're not sent, you're not going to your local pharmacy to pick these up. So as long as you can make sure the medication is safe and it's temperature controlled the way it needs to be. And secondly, that the member knows when they're getting their medication, it's easy to refill, etc. It is no different than what they're doing now. It's just coming from an international post office.
So said like a cartoon, right? I'm going to use my cell phone case as the example. This is the same drug, whether the taker of that drug, let's call it the patient, is in the United States, in Canada, in everywhere around the world. The same manufacturer of this drug is manufacturing it for the world. And it's now just called mail, right? Postage that is then deciding where it goes. It just so happens our country allows a significant upcharge on the cost of the drug. Other countries do not. So in the international thing, we're just saying we're getting that same drug that just made a pit stop in Canada and then getting sent to the employee's home, but it is exactly the same drug by the same manufacturer in the same box. It might have a maple leaf rather than a US flag on it, but
Or French on the other side. I mean, I don't want to paint the picture that there may not be multiple languages on the box, but it's the same thing. I mean, I would say, I live in Texas where we have a strong bilingual community, and the majority of the things I purchase have more than one language on them in the US.
right.
So it's really just a matter of, education and understanding. And, the other topic we haven't gotten to, and I would be irresponsible in my role to not bring this up and, talk about what does keep people up at night in the PBM space. And that is GLP-1s, which are, the Ozempics and the trizepatides and all of the different medications that were designed for type 2 diabetes, but have tremendous success with, namely weight loss, but other diagnoses. And, we're seeing it for sleep apnea. We're seeing it as a potential, cardiovascular benefits. I mean, the numbers are there. And that is the category that, employers really need to be paying attention to, because that does fall under my $3,000 threshold at an average cost of $1,300 before rebate per month. But you've got over 40 million Americans that have some form of diagnosis that actually could FDA qualify them for that medication. The BMI is being lowered to where, you're talking people who may only be 10, 12 pounds overweight are getting approved for GLP-1s and for weight loss and for, cardiovascular disease and other things. So that's another area, as we're talking to employer groups, you've got to be aware of how GLP-1 usage is going to affect your plan. I've been speaking all over the country, so I sound like an encyclopedia of facts. I've just done the same deck probably 30 times in the last month, but just some scary stats. I said 40 million Americans today have some form of condition. 1 in 3 Americans know somebody in their inner circle that are on these medications today. Here, I always do this when I have a large audience. Let's see, I do, so I already count, but do you know somebody in your circle that is on a GLP-1? So that it is as common today as almost taking, vitamin D. Like it is so common. And the third terrifying statistic is that by the year 2030, this is going to estimate $70 billion of a spend in a class of medication. $70 billion. And the other part that's scary is the 2030 is actually only 4 years away. It sounds so far off, but it's not. And so when you think about all of this and you think about your renewals, and you talked about stop losses only paying attention to the few, why are they not paying attention and helping? Because stop loss is also trying to figure out what they're going to do if the average American is all of a sudden on $12,000 a year of a medication, just as a given. I mean, it's like, yeah, over 40, between 40 and 50 and a woman, yeah, you'll probably be on that drug, like $12,000 underwriting cost. Like it's worse than, I have a 9-year-old, but I have friends that are starting to have 16-year-olds. I know you have a niece. It's like, I can't even imagine like auto insurance for 16-year-olds, but imagine like underwriting the population as if everybody is a brand new driver. It is like terrifying of what that's going to do economically. So why is this important? Because employers, this is all going to be how you strategize, how you cover these medications. What are you doing about cost containment with those things? Are you looking at the compounds of the medications or other format? I've seen that class go as low as $245 per month. So it's really staying on top of it, because if you don't, the repercussions are going to be enormous for every industry that are listening, because no matter what, you don't want a $12,000 factor per person going into your health underwriting, no matter how big your employer group is.
But Rachel, I hear this, and if I am an employer, I am like, okay, I manufacture widgets, right? I'm a financial services industry. I am the city of X and the school district of Y and whatever it might be. I am not in this business. It is why I have an insurance advisor that makes money off of me, and I pay my money to an insurance carrier. Don't both of those people aren't they looking at the same conversation, having the same things that you're doing? And I'm working with the biggest name carrier and the biggest name broker. Why are we having this conversation like it's one that is so like important? Isn't this like table stakes?
I mean, you would hope so. And that is where we get into, where interests are aligned and making sure incentives are aligned. If you are basically giving your consultant or broker a bonus every year that your rate goes up, and then that they get paid off the premium of your rate going up, you do not have aligned incentives. They are not truly trying to fight and bring it down. Now, there is some value in consultants who are able to take, that incurred report and fight it and get it to a level rate, right? And that's okay. Listen, if your consultant is coming at you year after year with, you had a 19% increase, I got you down to a 2, there is something in that. I'm not going to take that away from consultants that that's what they deliver. The problem is that, not problem. Have you and is your consultant coming back and saying, I figured out how we do this, but for less than we spent last year? That should be the conversation that you're having with your consultant. It should be almost a game. It should be the reason they're your consultant is to figure out how to do what you're doing better and less. That should be the theme every year. And it's not about, just shopping carriers and, doing the premium game. It's about why is it going to be less? And how are you going to engage the member? Again, let's go back to the beginning of this conversation. How many days have you been accident free, right? How many days are your people really working hand in hand to help the company not have anybody get hurt? How many ways is your consultant working to try to help everybody not only stay healthier, but understand the value that their benefit plan brings?
I want to end this in two ways. One, I obviously want to talk about a case study, but I also just thought about something. I want you to name me all the things that you can name me that if an employer's advisor or PBM or carrier come in and say that that employer should karate chop that person in their throat. Like something that we're like in the world of consultancy, we know that they say this. No, 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 that's not the right answer. Let's give some people some nuggets that when you hear this, red flag, red flag, red flag, you should say. So give me an example.
I mean, I can give it for all different categories. So let's go.
Let's give three that are like, wow, start running, help, help, help.
Okay. So the first one is any consultant that doesn't disclose how they're getting paid. Like if you can't figure out, so that's my small group advisors out there. Most of your brokers are paid on a commission basis. Let's not take that away from them, but you should know what it's based on, how it's based, and just have an idea so that you understand where your incentives are aligned. I don't want to pick on small group brokers. I just want it to be honest and understood. So that's the first one.
Okay.
Mid-size groups. Anybody I would say anybody over 50 employees. I'm going to go that low. If your broker is saying there's absolutely no way you should look at self-funding ever, that's a problem. Okay. So that would be, if you have I've had groups less than 50, but I'm going to just rule of thumb, stick with the state of New York because I think they are 50 lives and we'll just keep
100.
Right? Unless your state typically doesn't allow it, over 50, there is a strategy of some kind that would work for you in the self-funded world. Okay,
Love it.
that's number 2. And now let's go to my big groups, and I'm going to go with the area that is, beholden to my heart, and that is the pharmacy benefits space. If your consultant is telling you that they got you a contract with the deepest discount and you have no administrative fees or the lowest fees to pay your PBM, you need to either run or figure out like how the PBM is making money because they're making money and you're just not being told how. I'm going to couple that with if your consultant is telling you not only did they get you the best contract, but the word consortium is put in there with the name of their firm. So the big box PBM consortia, come aboard. Negotiated because we have gazillions and trillions of lives, and this is the best thing for you. If you haven't been paying attention, the largest PBMs with the most market share are the ones in the most trouble today. And that is the ones that back these consortiums. So, I just want to put that out there that those are, run for the hills if you don't know how the person helping you is getting paid. If they are, again, telling you not to look at anything other than your major carrier, or third and final, if you are doing business with vendors that are free. Does not make sense?
Yep. Yep. So let's wrap this up. Obviously, pharmacy is a big cost. We talked about some low hanging fruit. We've mentioned some specific strategies. What's the TLDY? No, I said that wrong. Too long, didn't read.
They had them like to do you list to
No, too long, didn't read. Uh, TLDR. TLDR. That is what it's supposed to be. Give me an example of a group, what they did, and what the impact was. And I want to leave the last thing of impact is how does it impact their patient population, their employees, and their families? Give me an example.
Sure. Group here. I'm very into the 340B and international strategy. We're self-funded, didn't had it we're in the middle of a 3-year contract with a PBM, couldn't do anything, no problem. We identified members that could get their medications from a local community hospital in Texas. We did custom reach out to 9 of the 300 members that had these high drugs, basically talked to them and said, "Here's a sign up. If you go to this pharmacy, you have no copay and your drugs are delivered within 24 hours." Not an international strategy. This was domestic. We had 0 people say no. In fact, people liked working with the local pharmacy so much, we had more people want to use them even for their cheaper drugs, just because it was easy and they door dashed the medications within the same day from the hospital. And we saved almost 60% off their top 7 medications within 30 days. And the PBM was still billed. I mean, it was just a new rate on 340B does take rebate revenue away, but the savings was immediate. Member have gotten, I mean, I've Google Rachel Strauss and rebates. You'll see how I have felt for many years on those. But the bottom line is that we were able to do something before their renewal. And, really what we're trying to do now is, figure out a way that we can cap pharmacy risk. There's a lot of tools out there using the companies like Brightwise and, putting in place now, or we can really get to the stop loss and control their future renewal with things we did while the plan was currently running.
Awesome. Awesome. Well, we could talk about this for 900 hours. There's a lot of low hanging fruit.
Who could talk more?
What's that?
Which one of us was talking more?
Well, and this show you because I'm interviewing you. In life, it would probably be me. So Miss Strauss, if somebody, I know you have a newsletter you send out. If somebody wanted to follow you, learn more about your services and where does somebody find you?
Sure. So I'm on LinkedIn, Rachel Strauss, or you can find me on my website, rachelmstrauss.com, or TikTok these days because I'm meeting the kids where they're at, the real Rachel Strauss. I like to
What does the M stand for?
Meredith.
Meredith. All right. All right. Well, Miss Rachel Meredith Strauss, thank you so much for being a guest on the Disrupt Healthcare podcast. To anybody listening, if you took away from this anything, I don't care if you're a solution provider. I don't care if you're a broker. I don't care if you're an employer. I don't care if you're just somebody randomly off the side of the street that picked this up. These are humans. This is like people's real life. And although I'm thankful that there are medications like Revlimid that my aunt has been on for 25 years and still alive and in remission, I'm thankful for all of these drugs that are, thousands and thousands of dollars and do some amazing life-changing things. But the majority of all of them can be purchased in some more economically friendly way that just allows the people who are taking them a better opportunity to continue taking them to do the thing that drug was intended to do. So if there's anything that you took from this, I hope that you took the people-centric side of this conversation, that if you as advisors, you as solution providers, you as employers just paid a little bit of extra attention to this one aspect of your healthcare spend, you could not only save gazungas of dollars, you could impact people's lives. And that's what we're all about. So thank you so much for listening. And you got one last game?
I have one more final thought. If you happen to be an employer that is supporting Lester and has worked with Lester for as long as you have, we need more employers to say you're already doing these strategies. I cannot say enough that healthcare is going to change when the people who have learned and are just supporters of this movement talk about it, please. Definitely tag Lester, but we need employers out there telling other employers that they've done it and that it works.
Which is the number one goal of this podcast. So thanks for saying it. Thanks for listening. Thanks for speaking on it. And we'll see you on another episode of the Disrupt Healthcare Podcast. Thanks so much.
Why? For disruptors.
See you, girl.